I am Dr. Saima presenting a case of a 22-year-old female patient who had a post-traumatic knee pain along with mechanical changes, which in this case was knee locking. When performing knee joint ultrasound, proper positioning and angulation of the transducer is essential to accurately visualize the different structures. The knee joint is typically evaluated in multiple views or angles. The interior view shows quadriceps tendon, suprapatellar recess, patella, and joint effusion. The medial view is used to assess the medial collateral ligament, the medial meniscus, the medial femoral condyle, and the tibial plateau. In the lateral view, we assess the lateral collateral ligament, the lateral meniscus, and iliotibial band. The posterior view shows the popliteal fossa, and it is used to assess the popliteal vessels, Baker's cyst, and posterior joint capsule. The patellar tendon visualization is done through the inferior interior view to assess the patellar tendon integrity and the infrapatellar pad. In this case presentation, the clinical background showed history of trauma to the left knee, presenting with pain, localized tenderness, and knee locking was the main complaint. The previous MRI reported patellar subluxation, patella alta, chondromalacia patella. Ultrasound was requested for further evaluation. High-frequency linear transducer was used to focus the lateral aspect of the knee joint. Joint spaces, synovium, and soft tissue was evaluated. Key finding was joint effusion and loose body, which was seen in the joint effusion. A well-defined echogenic structure noted in the lateral joint space. Located within the lateral recess was a free-floating body measuring 6.1 mm. This showed posterior acoustic shadowing consistent with calcified intra-articular loose body. Likely, this represented osteochondral fragment due to prior trauma. Lateral meniscus appears unremarkable. There was no evidence of tear. Lateral collateral ligament appears intact in this view. However, altered joint contour and lateral recess prominence suggested potential maltracking. Moderate anechoic to hypoechoic effusion is noted, distending the lateral patellar recess. Fluid surrounds the loose body, confirming intra-articular pathology. No septations or complex findings were seen. Intra-articular echogenic loose body in the lateral compartment of the left knee was likely post-traumatic osteochondral fragment due to prior trauma. Loose body in the knee joint is typically a free-floating fragment of the bone, cartilage, or a combination of both, and it commonly results from prior injury, degeneration, or joint disease. The main causes are trauma, osteochondritis dissecans, degenerative joint disease, synovial chondromatosis, post-surgical or arthroscopic fragmentation, and rheumatoid or crystal arthropathy. No adjacent erosion or meniscal displacement was noted. Mild synovial thickening is observed surrounding the echogenic loose body. Normal vascularity on Doppler and Gray scale shows no gross hyperplasia. Lateral meniscus appears unremarkable. No clear evidence of tear was seen. Mild synovial thickening suggests post-traumatic or reactive synovitis. Recommendations in this case was referral to orthopedics for evaluation of loose body management, particularly if mechanical symptoms like locking are reported. Consider joint aspiration if symptomatic to exclude infection. Correlation with prior MRI findings and possible follow-up with dynamic ultrasound to assess patellar motion. clinical monitoring for any increase in swelling, restricted movement, or persistent instability. Please don't forget to follow, like, and share this video. Thank you.